Hi, everyone, and welcome to this exciting edition of the Lympha Press Educational Webinar Series. I am Brenda Viola for Lympha Press, and if you were at NLN, you know what you're in for tonight. If you were not at NLN, I bet you heard about this presentation by Dr. Wei Chen, who actually really needs no introduction, but I want to do one because he's amazing and we so appreciate him. Professor and attending surgeon of plastic surgery at the Cleveland Clinic, an expert in supermicrosurgical reconstruction, a leading voice in the microsurgical treatment of lymphedema, taking a problem-solving approach to help patients find manageable ways to live symptom-free. And tonight, he's going to expand on his initial findings about lymphatic dysfunctions of the brain, groundbreaking revelations that could lead to treatments for Alzheimer's, Parkinson's, ALS, stroke recovery, and more. Now, this is groundbreaking material. We are so glad that you have logged on and are joining us. We will take questions at the end. This is being recorded and will be replayed, and everybody who registers will receive the link. Have no fear, because I know it will be a lot to take in just one sitting. But I am going to ask Dr. Chen to share his screen and take it away. And I want to again thank all of you for being here, but especially you, Dr. Chen.
Thank you, Brenda. And well, I appreciate the opportunity to share with you all our latest discovery. And as you can see on the slide, the title of my talk tonight is Rewiring the Brain, Unlocking the Brain's Lymphatic System. And we do believe that this is very likely the next frontier in supermicrosurgery. So I was just talking to Brenda about how this process really reminds me of about 15 years ago, where we were in terms of treating lymphedema of the arm and legs. And now I think in terms of reconstruction of lymphedema in the extremities, in the arms and legs, the field is maturing, the techniques are maturing, and even though we are still not consistently curing lymphedema, but we certainly are heading in that direction. And now we are going to expand the frontier to the central lymphatic system treatment of visceral lymphedema inside our torso, in our chest and in our abdomen, as well as lymphedema of the brain. So that's what we'll be talking about tonight. I have no disclosure. All right, so these are what I've been hearing from my patients from almost day one when I started performing lymphatic reconstruction of the arms and legs. So when I first started, I was performing lymph node transfer, and very quickly I expanded my surgical procedures to LVAs and various other surgical procedures. But mind you, these procedures were performed in my patients' arms and legs. And then they were telling me that their brain functioned better. They could think better. Their memory got better. And they had so much more energy. And this term brain fog was what I heard a lot, that their brain fog had lifted. And if this were a child, I heard parents saying that their child had a personality change. And that just didn't make sense to me. And early on in my practice, I always dismissed these reports as psychosomatic. Patient feel physically better. Well, the other way around, usually when we say psychosomatic discomfort, pain, we're referring to psychological issue manifested in a physical way, but in this case, it's the opposite. They physically feel better, and therefore they psychologically and emotionally feel better. And that remained the case, but I continue to hear these reports from my patients over the years that I've been treating extremity lymphedema, and I started to observe patterns. I started to see that we seem to hear these more frequently in, first of all, patients with primary lymphedema. And then we also tend to hear them more from the senior patients who may be more prone to cognitive dysfunction, who may be more prone to deteriorating memory, deteriorating mental processes. And when we do hear them from pediatric patients, and these are usually pediatric patients, young children with primary lymphedema, we tend to hear them in patients who are younger, prior to puberty. And these were the patterns that we started to observe. And you don't know this, but among the surgeons, lymphedema reconstruction surgeons, it's fairly well recognized by more and more surgeons that many of the lymphatic reconstruction procedures, whether we're talking about LVA, lymphatic venular anastomosis, lymph vessel transplant or lymph node transplant, or even lymphedema liposuction, we see two therapeutic effects. And one is catchment effect, and the other is systemic effect. Catchment effect means the surgery is helping the immediate environment where it is performed. So let's say a patient is suffering from leg lymphedema, and we were performing LVA to treat it. Then the LVA would be performed in the leg to help the leg lymphedema. So that's catchment effect, or what I call regional effect. Catchment or regional effect, where the surgery helps its immediate environment. The systemic effect means that a remote part of the body would improve also, that the surgery would have therapeutic effect on the remote parts of the body. This means that if I see a patient with lymphedema in both legs, as well as, let's say, penis and scrotum, instead of performing procedure on the patient's penis and scrotum, which sounds pretty painful, we could perform, say, LVA in the patient's leg, and we can expect therapeutic effect in the patient's penis, scrotum, as well as the other leg. And that's a great news. And so this has been confirmed in our own investigation. And actually, we definitely owe it to the community to publish our findings. But I certainly have been lecturing a lot about both of these effects. And this is what we have found for quite a while now. And we see that in all lymphedema procedures, and catchment effect and systemic effect. So now, is it possible that a surgery performed in the patient's arm or leg can, through systemic effect, help the brain? So that's the hypothesis. Can this happen? So early on in my practice, I thought there's no way, because we all know that the brain does not have lymphatics. That's one of the dogma. That's one of the classic teaching, that the brain is unique. The brain is special, even though our entire body, all of the organs have lymphatic system and require lymphatic drainage. But the brain is special. Brain is different. Brain does not have lymphatics, or at least that's what we thought. In 2012, the first brain's lymphatic system, the G lymphatic system, or the glymphatic, was discovered by Dr. Mike Niedergard. And glymphatic system stands for glial-associated lymphatic system. So you can think of it as, this is how the brain takes a shower. This is how the brain cleans itself. And interestingly, this is a system that's only active when we sleep. And that's probably why this system has remained undiscovered for so long. And actually, if that fortuitous afternoon, if Dr. Niedergard's mouse didn't fall asleep, we probably would have never discovered the G lymphatic system. But because of this discovery, we now know that brain does have a lymphatic system. Now, to help you visualize this, take a look at this animation. So this is inside the brain, and you can see this is a brain cell right here. And as this person goes about his or her daily routine, our brains start to put out waste material, as indicated by these yellow specks that are coming out from the neuron. This yellow cell right here with these end feet coming out are astrocytes. These are the support cells in our brain. you can see these end feet are lining this artery. So these astrocyte end feet are lining the arteries, and there are these channels called aquaporin 4 that are only open when we sleep. So I'm going to continue this animation. Now you can see more waste material, more garbage are being produced, and now this person will fall asleep right now. You can see the shrinkage and all these convective current represented by these blue dots are pushing all the garbage over to the vein side. So these transparent space surrounding the artery is called perivascular space. And there's similar perivascular space on the vein side. So the red is artery, the vein is blue. And you can see this convective current is rinsing, showering the brain and washing all the waste material to the perivascular space in the vein side. And this system is called the G lymphatic system. And that's how our brain takes a shower and rinsing off itself these waste material. Now, the G lymphatic system is only half of the equation. The second half of the equation was discovered by my partner, Antoine Louveau, in 2015, the meningeal lymphatics. And the meningeal lymphatics, as the name suggests, is contained in the meninges. Meninges are the lining of the brain. And as you can see in this slide right here, this empty space is a vein sinus. It's the sagittal sinus in the brain. And this is very interesting. In our periphery, in our arms and legs, the lymphatic system parallel that of the venous system. The lymphatics and the veins run together. Interestingly, this relationship continues in the brain. The lymphatics or the meningeal lymphatics run alongside the veins, and it tends to run right next to these major venous sinuses. And this picture shows you how the brain gets rinsed by the G lymphatics, and then the waste material gets delivered to the meningeal lymphatics. The meningeal lymphatics then carry the waste material out of the brain and carry them to the cervical lymphatics or the lymphatics in our neck. So again, this picture also shows that the meningeal lymphatics tend to run in parallel to the veins, the major veins in the brain. So this is our cadaveric dissection in search of the meningeal lymphatics. Here you can see the meninges being separated, the outer leaflet being flipped over. What you're seeing down there is the inner leaflet. And this dark blue line right here is the main sagittal sinus. Again, the meningeal lymphatics run alongside the sagittal sinus. These are microscopic structures, so we're not going to see them. But when we search for them microscopically, this is the location that they're usually found in. So as I said, brain not only has lymphatic system, it has two of them. And it's actually not too surprising that is the case, because we know that when we eat more, more would come out from the other end. When the brain consumes so much energy, it consumes 20% of our daily energy intake. 20% goes to the brain, and yet it only occupies 2% of our body weight. When it consumes that much energy, it has to put out a lot of waste material. And so the brain needs a very robust garbage disposal system, which is made up of these two systems, the G lymphatic system and the meningeal lymphatic system. Now, so these are the two longstanding dogma in neuroscience or neurology and neurosurgery. Number one is that brain does not have lymphatics because it is special, it has blood-brain barrier, it is immune privileged, and we know now that it's not true. Dogma 2 is that brain removes its waste products through central spinal fluid, CSF. Now we also know that's not true. So these two dogmas have now been overthrown. So these three pictures again show you what I've just said. The first picture here shows the G lymphatic system. Again, the perivascular space. When the animal or the person falls asleep, the G lymphatic system becomes activated, and this convective current carries all the waste material over to the venous side. And then the G lymphatic system, look at the second picture, hands over the garbage to the meningeal lymphatic system, which then carries, look at the third picture, these garbage out of the brain into the neck. And then once we get into the neck, it is fairly standard, normal-looking lymphatic system, lymphatic channels, just like the rest of the body, which then carries it to our central venous circulation and completes this circulation. Now, still, there's a third piece to the puzzle as demonstrated by this study. And it's interesting that as the brain accumulates garbage, let's say the brain's lymphatic system, these two cerebral lymphatic system broke down as the garbage starts to accumulate in the brain. Interestingly, we also see this parallel accumulation of garbage or toxic waste proteins accumulating in the next lymph nodes. And this was demonstrated in this murine study that we can find similar waste material in cervical lymph nodes, which parallel the accumulation of garbage in the brain. So putting all three pieces together, this is the analogy that I came up with to help you understand this better. You can think of the reservoir of your toilet as our brain. And as we use our toilet, garbage tends to accumulate in the reservoir. Could be growth of fungus, could be growth of all kinds of, or just sediments accumulated in the reservoir. And then we would take a brush to clean the reservoir. You can think of that action of brushing the reservoir as what the G lymphatics do. And then we would rinse the waste product. The product is carried out of the reservoir by the pipe. Think of the pipe as the meningeal lymphatics, which carries the material, the garbage, out of the reservoir, out of the brain, down the pipe. And if there's excessive waste products, it can clog the brain, resulting in clogging of the pipe further downstream. And that would be analogous to waste accumulation in the cervical lymphatics. So these are the three sites that we see problems in brain disorders, such as Alzheimer's disease or Parkinson's disease. And these also are the three potential therapeutic targets in terms of coming up with surgical procedures to treat these brain disorders. Now, this is another analogy. So assuming my house is our brain, and as we live in our homes, we start to produce garbage. And when wife starts to yell, I take the garbage out, and I would bring the garbage out of our house and leave it at the curb. So I would be doing the job of the G lymphatics. And then the garbage truck would come and pick up the garbage from our curb, taking it off our home premise. So the garbage truck would be doing the job of the meningeal lymphatics, taking the garbage to the recycling center, which would be the cervical nodes, and garbage starts to pile up at recycling center. So now with these two analogies, I think you can understand the concept pretty well, that the brain basically requires this constant removal of waste material. And if the waste disposal system breaks down, then of course our home gets dirty and our brain gets dirty and we start to have problems. So going back to treating brain disorders, now here I'm using these four examples: the Alzheimer's disease, the Parkinson's disease, Huntington's disease, and ALS. The common denominator of these brain disorders are that we have toxic waste materials accumulating in the brain, and they're called different They're called by different names depending on the specific proteins that are accumulating. But basically, these are brain's waste material. So which means that, so how come we couldn't treat these conditions in the past? Because we didn't even know that brain had lymphatic systems. Our diagnoses were wrong. So we all know that if the diagnosis is wrong, the treatment will be wrong. And the wrong treatment, of course, would have no hopes of being effective. So these two studies further confirm the cause and effect relationship. So we have already found out that in brain disorders such as Parkinson's and Alzheimer's, there are G lymphatic system and meningeal lymphatics that were broken. And these two studies takes it from a different direction. It selectively knocked out the G lymphatics and meningeal lymphatics. And these researchers show that by doing so, by knocking out either of these systems, you can reproduce Alzheimer's. You can create Alzheimer's disease by knocking out these lymphatic systems. So putting all these together, we can safely conclude that Alzheimer's disease and several other brain disorders are lymphedema of the brain. So we are lymphologists. I am a surgical lymphologist, so we know how to treat lymphedema. So these are the procedures that we currently perform to treat lymphedema. And as you know, there are two categories of surgical procedures. There are physiologic reconstructive procedures, and then there are mechanical debulking procedures. I think for the time being, we can safely remove and not consider the debulking procedure. At least as of now, based on our current concepts, I wouldn't recommend doing liposuction on the brain. So I think our focus for now should be on the physiologic reconstructive procedures. And we can also leave out the two transplant-based procedures because we're not about to move and take omentum and put omentum in the brain. So I think the more promising procedures would be the bypass type procedures, namely the lymphatical venular anastomosis, LVA, and lymph node to vein anastomosis, the LNVA. Now, for those of you who are not familiar with these two procedures, so LVA is the prototypical supermicrosurgery, and LVA is the technique that defines supermicrosurgery. And it basically involves identifying lymph channels and selectively pick out the lymph channels that are highly functioning in a patient with lymphedema. And we go in there and locate these lymph channels and connect the lymph channels to vein and therefore bypass and obstruct the lymphatic system. And the obstruction, let's say in the case of arm lymphedema, patient who had breast cancer, had lymph node dissection and radiation, and developed arm lymphedema. We know that the injury is more proximally based in the armpit, and we can perform a bypass in the arm connecting the lymph drainage or the lymphatic channel to the vein, and now the vein starts to take over the job of the lymphatic system. And the video in the center that you're seeing, I was performing an LVA procedure. That purple color vessel is a vein, and the green color vessel is a lymphatic. And that is an LVA. The lymph channel measured 0.3 millimeters, and the vein measured 0.9 millimeters. For those of you not familiar with metric system, an inch is 2.4 centimeters, and or 24 millimeters. All right, so that's LVA. And so this is lymph node to vein anastomosis, or LNVA. LNVA is taking a lymph node. You can see in the video right there, I was about to poke a small hole, and this is a microscopic hole that is a 30 gauge needle, tiny, tiny hole with a needle. And you can see the lymph oozing out with a little bit of blood tinge, lymph drainage. And then, by the way, this is magnified for about 30 times. And the tip of that forceps you're seeing is 100 micron or 0.1 millimeters. So now we sew this vein to the lymph node, and now the lymph node started to drain into the vein. And the sutures that you saw briefly right there, that suture is significantly smaller than our hair. So this is also a supermicrosurgical procedure, and this is the lymph node to vein anastomosis. Now, going back to the 3 potential therapeutic targets of the brain. So we talked about G lymphatics, we talked about meningeal lymphatics, and the cervical lymphatics. Now you can look at their sizes. They range from 70 micron of the G lymphatics to 70 to 800 micron for the meningeal lymphatics to 100 to 900 micron for the cervical lymphatics. Now, supermicrosurgery is 100 micron surgery from 100 micron to 800 micron. So you can see that at least today, given the current state of the art in supermicrosurgery, G lymphatics is still a bit out of our reach. Whereas meningeal lymphatics can occasionally, when it gets above 100 micron, would be within our reach. But cervical lymphatics is perfect. The range, the caliber is perfectly, it sits middle with supermicrosurgery. So it's definitely within our reach as of today. And also, if you look at their location, both G lymphatics and meningeal lymphatics are intracranial. We need to open up our skull to access these 2 systems. Whereas the cervical lymphatics, they're in the neck. We don't need to open up the skull, and therefore the surgery is by design much, much less invasive. So just considering all that I have mentioned, and also considering what I have mentioned earlier, that we don't have to operate on the brain in order to treat brain's lymphedema, because of the catchment and systemic effects that I had explained earlier. So we just need to be close enough to the brain, and the surgery may be helpful to the brain. And therefore, considering all that we have just discussed, cervical lymphatics or lymphatics in the neck is the most ideal location for our surgical intervention. So our procedure of choice is LVA and or LMDA on lymphatics on the neck. So with that design, we started working on our animal studies. So we have using transgenic mice. These are mice that are designed and programmed to become demented, develop Alzheimer's at 2 months of age. And we would then go in and perform LVA and LMDA to try to treat their dementia. And the mouse cervical lymphatics are substantially smaller than human cervical lymphatics. So these surgery is quite challenging, but definitely still within reach. And we are supermicrosurgeons. We don't back down from these technical challenges. So far, our study is ongoing, and we're not quite at a stage to announce our findings yet. But what I can share with you is that our preliminary findings are encouraging. And early this year, 2023, we have discovered that Professor Xie from China, to our surprise, had actually already performed such surgery successfully in human with very similar surgical design. So as we always said in the research world, don't think that your idea is unique. For sure, there are others who have thought of similar things and are working on the same topic as you. But what Professor Xie didn't have, we have. What he didn't have is basic science research and animal research. And what he has already done, the human trial, we haven't started yet. So we reached out to him, and we decided to collaborate to help each other. And so now we're in this together, we're collaborating, and his human trial data from his human trial will help us when we finally get started with our human trial, which currently we are in preparation of launching. And by the way, as a side note, right now we are working on securing funding for our human trial. As you can imagine, offering these procedures to patients require funding. Each surgery needs to be paid for. So if you happen to know anyone who is interested in contributing to medical science, contributing to medical research, and is interested in helping out with such a research, please let us know. So here is Professor Shea visiting Cleveland Clinic and with Antoine and myself. And here we were working, operating together, doing simulation surgery on cadavers and essentially sharing and learning from each other. Since we haven't performed any human trial yet, but I'm sure everybody wants to see how well or how does it even work after me talking about this much. So I will share with you a case of Dr. Shea's. And this is a gentleman, 76-year-old with severe cognitive deficits who was diagnosed with late-stage Alzheimer's disease. And he actually couldn't recognize anyone. He couldn't even recognize his families, his own son and daughter. And he had incoherent speech. He couldn't take care of himself. Basically, any basic tasks of daily living, he couldn't eat by himself. He couldn't dress himself. He couldn't go to the bathroom by himself. And he had fecal incontinence. He would actually pick up his feces and throw at the care worker. Basically, he required around-the-clock care. So he would be speaking in Chinese, and we have put on subtitles so you can read the subtitle and just observe his facial expression and his affect. All right, so this was him prior to surgery. And this is his response only a few days out following surgery. So this is where we see another parallel of how the brain responds to lymphatic reconstruction as compared to how patients respond to peripheral lymphatic reconstruction, lymphedema of the arms and legs, in that these procedures work almost instantaneously. So this is just a few days out. You can see he was already recognizing his son. So his affect was still not completely appropriate, but he was recognizing his son. Here he was 6 months later, and with this video, you can clearly see how he has improved. Observe how he will be sitting down unassisted. And he now had coherent speech, and he could recognize everyone, recognize all of his family, and then he will be getting up from the chair with minimal assistance, and he was now going to toilet by himself. And as compared to prior to surgery, he was quite vegetable-like. He was laying there, not doing a whole lot.
Hay好吗？认识我吗？认识我吗？我老干部了。吃饭现在好不好？吃饭吃的好吗？吃饭可以，能吃多少啊？吃1碗吃2碗，1碗可以的。你喜欢吃面还是吃米饭？喜欢吃米饭。你儿子叫什么名字啊？女儿呢？秋月。 陈啊，儿子女儿每天来看你吗？天天来看你的啊，你不吹牛，天天来看你的，还是经常来看你吧？能不能站起来给我看看？自己站起来，自己站起来。哎，对啊，再问我慢慢来，帮你一下。哎，嘿，好，走两步好吗？可以啊，走两步很好。现在人舒服吗？人舒服吗？人舒服的。大便好吗？大便自己拉吗？都正常，自己拉大便。以前的事记得住吗？以前在其他医院治疗的时候，你知道吗？还可以啊。
All right, so this is 8 months later. So if you recall in the beginning, he couldn't walk, he couldn't even sit up, but now he was running away from the nurse. And in the second video, he was singing, and singing required higher brain function than just talking.
一夜夜间，不掉一只，才能在手里。
All right, so as I said, this progression really parallel what we have been seeing in lymphatic reconstruction of lymphedema in the extremities. We will see instantaneous improvement following lymphatic reconstruction, and then progressive and continuous improvement over time. In the lymphedema of the arms and legs, we usually see this trend, improving trend for 1 to 2 years. And the longest continuous improving trend we have observed in the extremity is 6 years. So in this patient, the follow-up was up to 8 months. By now, this patient had further follow-up, but we will need to continue to follow him. All right, so with all that, can we really conclude that we have a treatment for Alzheimer's and Parkinson's? I think that there are reasons to why we are cautiously optimistic that this may work. So even though there's already these fairly impressive cases with dramatic before and after improvement in behavior and cognition from these cases that we've seen from Dr. Shea, but we are still awaiting our own human trial, and as well as definitive evidence from our animal studies. So what we have now, as I said, are some very observable and clear-cut improvement in patient behavior, in their cognition, speech, motor function, and behavior, as you have seen in that case example I've just shown. And so Dr. Shea, the Chinese researcher, also have demonstrated some fairly clear-cut improvements on these clinical scales, commonly used clinical scales, the MMSE and MoCA. But for something this significant, we really need even higher quality evidence. We need to look for biomarkers. Well, we already have pre-existing biomarkers. We need to demonstrate that there is a difference pre and post treatment in both animal and human. We also need imaging-based evidence that these treatments work, and as well as various other more definitive evaluation. So right now we're working, this is our research focus, and give us a bit more time and we will get back to you with when we have further progress in our study. And so the treatment of Alzheimer's and Parkinson's, as well as several other brain disorders, is just the beginning, because the field of lymphology is still developing. Lymphatic system has been one of the most neglected and ignored organ system in human body. And we are just starting to realize how important it is. It is involved in so many other disease processes. Many of those are currently considered untreatable. Here are just some of the examples. And by the way, the lymphatic system is also found to be damaged, significantly damaged, following stroke. And therefore, the lymphatic reconstruction in stroke patient following a stroke has been found to be implicated, that it's incredibly important in functional recovery in stroke patient. So we can already expect that there's a lot more to come. And but most of what we can predict and already foresee are favorable. We're likely to be able to start to treat and get a handle on many of these currently untreatable conditions, or conditions in which patients have very few options. So, okay, this slide is probably, I don't know whether there are researchers in the audience, or other lymphedema surgeons or lymphologists. I used this talk just last weekend. I was lecturing the lymphatic supermicrosurgeons worldwide. And so this is my invitation to them, that now that the genie is out of the bottle, this is what we've been working on in the past 6 years without keeping it a secret. But now we are announcing it to the world, and we're inviting everybody to join us, because when we put our brains together, we're likely to find a solution sooner. That's all I have. And thank you very much.
That's a great last slide there. And I have to tell you, I feel thrilled, and I know many of our audience members do as well. When you presented this at NLN, it was a standing ovation and people had tears in their eyes. This is a seminal moment. And while you've been giving this presentation over and over, for us, it's fresh and new, thrilling and exciting. There are lymphatic therapists in the audience, those that focus on the brain as well. We want to thank you, Dr. Chen. We do have a question from the audience, and if there are other questions, please do put them in the Q&A. From Ted B, have you found a correlation with lymphatics of the brain and idiopathic intracranial hypertension?
I think it would be premature to say that we have found correlation. There's certainly lots of hypotheses. And since our initial announcement of our discoveries, early discovery, we have been reached by many leading neurologic institutes from around the world. And yes, that have been mentioned, that correlation have been suggested, which means that we could potentially treat what you have just suggested and several others. As I said, this is the very beginning. We want to be cautiously optimistic, and at the same time, we need to make sure that we are practicing good medicine and we are practicing good science here. We don't want to overpromise. We need to be very careful with every step. And that's why, despite what the Chinese surgeon has shown, those are some impressive clinical results. We're not quite ready to announce that, yes, we're treating, we're welcoming all Alzheimer's and Parkinson's disease patients to come in, and we're starting to do surgery. So that's where we are today. And as I said, we're in the process of preparing for a human trial. So stay tuned. And if you know anyone who wants to donate, please let us know.
That's where I was headed next. So you never know who is in our audience or who will be watching the replay or who they might know as connections. Where do we send them if people want to fund this research? Does it go to Cleveland Clinic Foundation?
So we have a philanthropy office here at Cleveland Clinic. You can certainly reach out to them. Just indicate that you're interested in supporting our brain lymphatic reconstruction project associated with Dr. Chen and our Neurologic Institute.
Fantastic. So we have both clinicians and patients in our audience, and I appreciate so much your accessibility to everyone, Dr. Chen. Angela Parsons is a lymphedema patient, and she wants to know if when the lymphatic toxins are getting clogged in the neck, can that cause neck pain? She feels pain in her neck and her head, and then she can feel lymphatic fluid building in her hips and legs.
And
we don't diagnose here, by the way. I'm not going to offer medical advice at all, but I think what she's doing is connecting the dots to what you said. And, you know, obviously we're all looking for answers and relief.
Yes, I think you certainly are welcome to connect the dots. That's what we call hypothesizing. But hypothesis is not proven, it's unproven. It's premature to say that lymphedema of the brain, that patient with Alzheimer's disease, say, for example, will have neck pain as a result of these toxic protein accumulation. And by the way, what I have just shown you, that is one study. And you should know that in medicine and in science, we dispute just because something is published doesn't mean that it's undisputable. Actually, we dispute and debate all the time. As you probably, if you're a patient or a lymphedema, actually, whether you're a patient or a lymphedema therapist, you know that in the field of lymphatic reconstruction surgery, surgeons debate all the time. And actually, even though we do so in a civilized manner, we agree to disagree, and we convince each other with scientific studies and evidence, instead of saying, this is what I think, this is how I feel, this is what I believe. Well, in science, we don't believe, we prove with scientific evidence. So yeah, it's important that we make that distinction. As I present these most exciting latest data and discoveries to you, I think we should keep that in mind. There are certainly lots of things that are possible. There are also the possibility that we might be wrong, and well, and that's science. And we, since we are leading currently in this area, we have the responsibility to get to the bottom of it. So, as I said, the whole thing may lead to a disappointing end result, but if that were the case, we have the responsibility to find out that this doesn't work, and then we try something else. But at least we know this doesn't work.
Well, 15, 20 years ago, what you were doing in supermicrosurgery wasn't happening. And so I am thrilled and excited about the progression and where we are headed. And every failure leads to an eventual success.
Exactly.
Yes, we are committed to seeing lymphedema patients get help. And then if all these disease states can be helped as well.
For the scientists in the audience or for the medical researchers, if you are interested in this process of discovery, I would recommend the book Puzzle People, written by Dr. Starzo, who's the father of transplant surgery, liver transplant. And Dr. Starzo encountered a lot of failure in the beginning, and everybody was accusing him, blaming him of hurting patients. And had he given up, he would have gone down history, someone who is hurting patient. But he didn't give up. He had it worked out, and we can see the end results. How many patients have been and will be saved by organ transplant?
And I love what you said. We are super microsurgeons. We don't back down. That was a bold statement, Dr. Chen, and I love it. Question from Laura Middlestead. Do you think MLD could be used to treat these diseases?
I think certainly possible. I do invite lymphedema therapists to also come up with treatments. Yes, there have been therapists reaching out to me saying that, yes, such treatment had already been developed. So I would encourage, as I have said, we need to be very cautious in what we are claiming. So if there have been treatments already developed, I would invite these pioneers in lymphedema therapy to conduct scientific investigation. And I mean, these are well-proven pathways to demonstrate validity of treatments. Don't keep it to yourself. Don't keep it exclusive. Because when you keep it exclusive, you are only treating a small number of people. You need to publish your results and teach others, teach clinicians worldwide so more patients can be helped. And but you need to prove, you need to show scientific evidence instead of just leaving it anecdotal. And that's what I see a lot, which is unfortunate. People are keeping it to themselves or leaving their treatments, which could be the biggest discovery, as anecdote, which means that they would go to meeting and said, this is how I do it, and it works. And I've been doing it for 20 years. Well, you've been keeping it to yourself for 20 years. So yeah, so I definitely, I think it's possible. In the past, we couldn't treat these problems because we were wrong. We had the wrong diagnosis. And now we know that these are lymphedema, and I certainly think that's possible. That MLD, not necessarily just MLD, can we manipulate the lymph node? Can we declog the brain without doing surgery? Yeah, I think certainly possible. Or maybe is there a pill that could be developed? Are there exercises that could be done? Yeah, certainly possible.
There is a lot of chatter, and I love when our participants end up talking in chat. What about this? And what about that? And it all is going along with exactly what you just said. Having these invigorating conversations and not being afraid to be wrong, but it can provoke the connecting of the dots, which is what is really invigorating. Patricia Little is out there, and she had mentioned that wouldn't it be amazing if the NFL was interested in funding this? There are so many athletes with CTE. Wouldn't it be incredible if a portion of every ticket for an NFL game went to lymphatic reconstruction surgery? Wouldn't it be amazing when this becomes commonplace and known, and all we can do is say thank you to a mouse that fell asleep?
Yes, I think at least what we can already recommend is sleep is incredibly important for our health. And so you might have heard that scientists didn't know why we need to sleep because none of our organs seems to be requiring sleep. But now we know the brain needs sleep. And we all know what it feels like when our brain is filled with these metabolic waste. All you need to do is to stay up tonight, and you know what it feels like in the morning.
Foggy brain, for sure. And so if someone has obstructive sleep apnea, again, that's interrupting your sleep. I mean, we're just talking out loud here, but so many people have CPAP machines, and even though they don't like the machine, they like the results because is their brain cleaning out more?
Right. I mean, certainly these discoveries have lots of implication. So, and we can go on and on hypothesizing. Certainly, does that mean people with poor sleep are predisposed to brain disorders? Possibly. Again, these discoveries are so new. Without further study, we can't. I think we can certainly make that hypothesis. It's not without basis. But again, that wouldn't be science. We will need to confirm that and prove that. But certainly it's reasonable to hypothesize that there may be a correlation.
I want to thank you for your time. Do you have any closing words for our audience that are here live or who will be watching the replay?
Well, I think the one key message for the patients in the audience, know that you may be thinking that you've been ignored. Well, that might be the case in the past, but not anymore. Now, lymphatic medicine, lymphology is the hottest topic. One of the hottest topic. It certainly is the hottest topic in reconstructive surgery. Now, all of the best reconstructive surgeons want to be lymphedema surgeons. They all want to help you. So don't feel that you're ignored. You're not, at least not anymore. For
Wow.
all the clinicians in the audience, the key message here is that there is no dogma in medicine. So please let go of what you were taught. By the way, your teachers, when they taught you, I don't know whether it's 10 years ago, 20 years ago, they might be state of the art. They taught you the best, the state of the art in their time. But if you are done, if you are an experienced practitioner, you finish your training 20 years ago, I hope you're not still practicing what you were taught 20 years ago, because that means you haven't moved forward. That means your practice dwell 20 years ago. When was 2000, 2002? Actually, when I gave the NLN talk, I discovered that I became a board certified surgeon the year iPhone 1 came out. And I certainly, I was fortunate to train under some of the greatest surgeons in the world. And, but state of the art in 2007, when iPhone 1 came out, should not be state of the art today. Just like iPhone 1, we're at iPhone 15 or 16 today. And iPhone 1 is archaic. iPhone 1 doesn't belong in 2023. So, and I am happy to tell you what we practice today in lymphatic surgery has no resemblance to what we practiced in 2007. And so, let go of the dogma. State of the art today should be obsolete tomorrow. And we should have something better tomorrow.
And thanks to people like you, we shall. And I hope you get all the funding needed so that you can do all the research that's in your heart to do. Thank you for being such a leader in this field and showing the patients that they are not alone and that someone does care enough. You've devoted your career to this. Lympha Press is honored to host these webinars. Yes, we provide pneumatic compression therapy, and we hope that you're using it for your patients, but we also want to support both patients and clinicians. And that's why we provide this leading edge content and why we have support groups for both lymphedema and lipedema patients. We believe in connecting those dots together and supporting you. And we want to thank you all for the work you do to make life better for patients. So with that, have a great night, everyone. And thank you, Dr. Chen.
Thank you. Good night, everyone.
See you.